Hi, Terry Schoenfeld here for UAB School of Medicine. In part 2 of this two-part series on how to read a therapy study, I'm going to go over the remaining 3 questions that you need to answer as you read a therapeutic study.
So in part 1 of this two-part series, we looked at the first 4 questions, the randomization questions, when critically appraising a therapy study. In this part, we'll look at the last 3 questions that we should answer as we read and critically appraise a therapeutic trial. As a reminder, we're reviewing the RALES study, a study which randomized patients with congestive heart failure to spironolactone or placebo. The patients had to have class 3 or 4 congestive heart failure, had to be on an ACE inhibitor and a loop diuretic, and have a left ventricular ejection fraction of less than 35%. So let's look at the first question. Was follow-up sufficiently long and complete? So the duration of the study needs to be long enough for the outcome that the authors are trying to impact to occur. This requires your clinical judgment and knowledge about the natural history of that disease and the potential impact of the intervention on disease. The second part of this is that every patient that's enrolled in the study should be followed up until its completion. We don't want to lose people. We lose information by losing people. And it's especially important if we differentially lose people. What I mean by that is more people lost in one arm of the study versus the other, because that might be related to the intervention and it could be related to the outcome. And we really start to worry when large numbers of patients are lost from a study. How much is too much? Well, one rule of thumb that's often used in randomized controlled trials is that 10 to 20% is the top end of losses to follow-up. Any more than that, you really start to worry, and that these losses are a threat to the study's validity. What you'd also like to see is if there are patients who are lost to follow-up, that the authors keep track of them and maybe even tell you something about them demographically so you can make sure that they're similar to the patients that remained in the study. So here's an excerpt from the RALES study. Pause the video, read this, and see if you think follow-up was sufficiently long and complete. When you're done, restart the video and see how I answered this question. So let's see how you did. So the mean follow-up of patients in the RALES study was 24 months or 2 years. This may not seem very long, but advanced congestive heart failure, especially back in the 90s, was a very lethal disease. Patients didn't live very long. 1 to 2 years was the maximum many of these patients would live. So this clinically at that time was a reasonable period of follow-up. So they get credit for that. How complete was follow-up? Well, they talk about during the study, 400 patients were discontinued treatment and stopped really participating in the study, 200 in each arm essentially. But the nice thing that the authors did is they kept track of everybody and determined their vital status or their outcome. And the outcome of this study was mortality. So they were able to figure that out in this study, even though the patients stopped taking their treatments. So I give them sort of a plus minus on this. They meet most of it. Been nicer if all the patients would have remained in the study, but at least they knew what happened as far as the outcome goes of mortality to every patient who was enrolled in the study. Question 6. Were patients, clinicians, and study personnel kept blinded to treatment? We don't want anybody to be able to figure out what arm of the study a patient's in. We want the patients blinded, researchers, physicians, statisticians, everybody that we can blind, we want blinded. And the reason is if you know what arm of the study somebody's in, it could affect the care that you give them, and it could affect how you assess the outcomes that occurred. Now, sometimes you can't blind. So, for example, a medical versus a surgical study would be pretty easy to figure out what arm of the trial somebody was in. Just have to look for a surgical wound or a scar. Sometimes we can figure out because the drug has some predictable effect. So let's say I had a statin study. All I'd have to do is check labs on my patient. If their LDL went down when they started the study, then I know they're on active therapy. If I start a postmenopausal woman on hormone replacement therapy in a trial and she starts having her periods again, I know what arm of the study she's in. So sometimes you can figure out what arm of the study somebody's in. So what should you do? What you'd like to see is that the adjudication committee, or the group of people who sort of absolutely confirm the outcomes, that they're blinded to what arm of the study the person was in. So that's sometimes the best you can do. Now, a study published a few years ago in the British Medical Journal showed that blinding is often not done and can lead to overestimation of treatment effects. And again, what overestimation means is showing more benefit than was really there. And this mainly occurs in subjective outcomes. And what subjective outcomes means are things that nobody could absolutely look at it and come up to the same answer. It's subjective to how you interpret it. So things like quality of life, pain are very subjective, and different people will give different answers. Things that were objective, like death, were not affected by the lack of blinding. So if you see a study isn't blinding or that people could figure it out, look at the outcomes to see if they're subjective or objective outcomes. If they're objective, you can feel a little bit more comfortable that blinding had little impact on the outcomes. So let's see how the RALES investigators did. How did they do as far as keeping patients and other personnel involved with the study blinded? Pause the video, read this excerpt, and then restart to see how I answer. So let's see how you did. So they talk about this study being a double-blinded study. And what double-blinding usually means is the patient and the researcher. But you really never know. So you really like to see the authors tell you exactly who was blinded so you can make some judgments. But at least they say it was blinded. But look at this. They measured serum potassium throughout the study. Could you think patients and researchers, could they figure out if a patient was on spironolactone or not? They probably could. Spironolactone usually raises potassium levels in patients. It often causes breast pain and gynecomastia in men. So probably you could figure out in this study which patients were on spironolactone, which patients weren't. Again, the question is, does it matter? The outcome was very objective. It was mortality. So it might not matter as much. The other thing they did is that the Data Safety Monitoring Board and the Adjudication Committee were blinded. So they did the next best thing they could do. The people determining outcomes didn't know whether somebody was on spironolactone or not. They couldn't have figured it out. So they did the best they could do, so I give them a check mark for this and think that the study meets this criterion. Finally, were the groups treated equally apart from the experimental therapy? We should do the same thing in both arms. There should be similar intensity of follow-up, similar quality of care provided to both groups. We call these other things that could happen to participants in the study besides the new treatment. We call them co-interventions. We want both groups of people to have the same opportunities to get these other co-interventions. Now, sometimes the co-interventions will be done differently in the two arms, but we like to see it the studies designed so that this isn't purposely done, that only one group can get something and the other group not. And now the reason some groups will get things differentially done is because of the outcomes that are occurring in the study, and the doctors have to respond to those outcomes. But the key here is look to see if the study's designed that everybody can get the same thing. Not that they did, but that they could get it. And this is often very hard to determine. Authors don't spend a lot of time writing about other things that could happen to patients to reassure you that they were done equally. You have to really kind of pick through the paper and try to see if you can figure it out. So let's test those skills and see in the RALES study if you think the groups were treated equally. Pause the video. When you're done determining this, restart the video to see how I answered it. So let's see how you did. Again, very difficult to figure out. Best I could tell from the RALES study is that they had similar periods of following up. They were measuring labs in everybody the same way. So I gave them credit, even though I don't know all the other things that they did to people. Authors can't spend a lot of word space in studies telling you all the other things, so it's somehow very difficult to figure out. Often you'll have to look at other tables of the paper and see some things that were done, but unless it's obvious, you're going to have to rely on some judgment here. There's nothing much better you could do unless you maybe contacted the authors. So in summary, my assessment of the RALES trial, I feel it's sort of low to moderate risk for bias. Why do I say that? Well, the study was randomized, but they didn't really conceal allocation that I can tell. So there's likely a small overestimate of the benefit of spironolactone in this study. Randomization worked well. The groups are similar at the start of the study. They used intention to treat analysis. Blinding could have been figured out, but they blinded the important people who figured out the outcomes. And lots of people stopped treatment, but they were followed up, included in the analysis, so I feel a little bit more comfortable. And I feel comfortable going on and now reading the results section and potentially applying this to a patient.
So I hope you understand more about how to read a therapeutic study. Remember, if you have any questions, you can contact me through the course website or through the Contact Me section of my blog. Have a great day.